2. Hello, everyone. I am so excited about today's presentation and even more excited about today's presenters. So we have Dr. Scott Munsterman and Dr. Steve Conway here to answer all of your Medicare questions. And really, there are no two better people to really give you an answer to those questions that have been plaguing you in practice. Dr. Munsterman, for those of you who may not know, he is the CEO and founder of Best Practices Academy. He is also a chiropractor, has been Chiropractor of the Year in South Dakota, is also a fellow of the International College of Chiropractors, has served 2 terms as mayor for the city of Brookings and 3 consecutive terms in the South Dakota House of Representatives. And to be real honest, he is just a really cool guy. Our other co-presenter today is the Dr. Steve Conway, who is also a healthcare attorney. And really, seriously, these are the guys who are working on the front lines who really know the answers to your probing questions. Again, has an incredible background in chiropractic, is a second-generation chiropractor, was the vice chair of the ACA Medicare Committee, worked with Dr. Michael Jacklich with the ACA's and Medicare documentation program to really help doctors all across the country be compliant with Medicare. So, listen, I could go on and on for days about how amazing these two are, but I'm going to be quiet, turn it over to them so you can see for yourself. Welcome, guys.
Hello. Hey, thank you, Christy. So I just want to echo Christy's comments about Dr. Conway and Dr. Jacklich. When I look back over the last probably 5 to 7 years in that range, I've just seen some tremendous changes in how, well, when you think about it, the healthcare industry in general, we've gained more value, more respect, but in the area of Medicare, where we've needed it the most and the most frontline work, those 2 gentlemen have really done the job. And what they've done is that they've been able to successfully visit, talk, educate, negotiate, whatever you want to call it, with Medicare administrative contractors, the OIG, and the like, about chiropractic. They've been just fantastic representatives of our profession. And now what we're able to do, Dr. Conway and I, and of course through ChiroHealthUSA, is to help you folks understand, okay, what is it that we need to know? And Dr. Conway, you know, you've summed it up with this title quite well, 99% of your Medicare questions answered. And really that's what we're going to kind of venture into talking about, is what's causing 99% of the Medicare denials.
Yeah, it's been interesting. And this has been over a 5-year project with Dr. Jacklich and myself, and Dr. Munsterman too. You've done a lot of work with the MACRA and MIPS, and leading expert in that. So all of us have been playing in this Medicare field to help our profession. And what we're going to go over today, because they asked us, what is, if you could get one thing, the one thing that's really causing it, or what's the issue, what would it be? And that's what I want to go over in this time that we have today. There's multiple things that you have to do. So please don't think that just the one thing I'm going to show you today that's all you have to do. But really, everything I've been working on, and I've been doing this for quite a bit in, like you said, negotiating and working directly with all the Medicare carriers. We've had them all in the same room working through these issues. But also I help chiropractors across the United States dealing with Medicare audits. So I'm watching how they're being audited, why they're being denied. I'm dealing with all these administrative law judges, asking questions, and it's always boiling down to one thing, that the chiropractors, if they could change this and modify this one thing, it would actually solve, I believe, about, maybe 98, 99% of the issues that they're having on Medicare. And so that's what we're going to go over today. I'm going to show you that one segment of it, but please understand that there are some other components that are equally important. You have to have these other ones in as well, and we don't obviously have time today for all of those, but we'll talk later ways they can get that information. But today we're going to hit that one, and it really boils down to the initial visit. There's the initial visit, and then there's a subsequent visit. But on the initial visit, how you actually write your treatment plan is the key factor that is going to change everything that you're doing with Medicare. And so that's what we're going to go over throughout today.
Yeah, very cool. And Dr. Conway, and of course, everybody's going to be able to better understand that as we move along here. And and recap at the end and all of that. But talk to us a little bit about maybe what's going on out there that we should probably know about.
Yeah, there's a couple of things, and I bring these up at every one of my presentations just because, again, I want to protect the chiropractic profession. And when I come across something that is affecting chiropractors, so these are real stories, they're affecting chiropractors, I want to make sure that the rest of the profession understands the severity, and just to make sure if they're somewhat doing this or touching near this, that they should at least change what they're doing or reevaluate the procedure. So there's actually a case, and our slide here talks about a current case, but it's actually been finished now. And it's a case that I was assisting in. It was a big case. But this case basically involved a really nice chiropractor. So this is not like a person who was kind of like coloring outside the lines or doing things where you say, well, it's kind of questionable, or I don't know if I would ever do that. This is your average chiropractor that probably every person listening on this phone today, to the seminar today, would relate to, a really good person. What happened with them, he had the Department of Justice knock on his door and basically asked him for a lot of records. So whenever you get that, it's a scary thing to begin with. But when we started the process with them, we asked, what is this investigation about? What are we looking for? What is the issue? Because we're just trying to figure out what really was at hand here. And what was going on was they claimed, and what was going on, the chiropractor was providing free services to Medicare patients. And so we started looking at this a little deeper, and and they basically know almost everything that you do. It's amazing what they do with their statistics. But they had done a research and looked at this specific chiropractor, and they had found that, or they assumed that, and they wanted to find out in this investigation, was he providing free therapy to Medicare patients that were coming in his office. So thus he was actually doing the adjustment and billing for that, but at the same time, he was allegedly, and what they're working with, was giving maybe 2 to 3 minutes to a Medicare patient on ultrasound, or it was actually electrical stimulation. And they also wanted to look to see how he was coding his patients when they move from active treatment down to maintenance. And that's a key factor. And again, this is where ChiroHealthUSA helps a lot of the chiropractors stay out of trouble when they're getting in the coding, when they're moving through this area. And this specific chiropractor had a procedure where he would, again, I think being kind to his patients, thinking this would cost less, he started shifting them all down from a 98941 or 42, that all the maintenance patients became a 98940, which they're looking at it like, how can that be? What was happening there? So we're looking at the process of giving away free services, not a lot, but just enough that they felt that this was an inducement for Medicare patients to bypass other chiropractors in the area and to specifically go to this office. And it was a very long case that we worked with, and whenever you get in with the Department of Justice, it's not a quick process. But at the very end, we're looking at it, and the chiropractor, sometimes you just have to settle, really what it is. So if you read this case, you will look and see the Department of Justice position on it, because it's very difficult to fight these. But the key thing I want to get across to all the chiropractors or staff that are listening on the phone here is we need you to look at the compliance within your office. And when you're dealing with Medicare, federal programs like Medicare and Medicaid, you have to charge for your examinations, you have to charge for your x-rays, you have to charge and receive the payment of any therapy you give, any services that you give to this level of patient. You have to make sure that you are correctly charging and receiving the payment from it. So it's a big case that was out there. I know a lot of chiropractors have big hearts, and they try and help their patients, and they're working through it, but the risk is very high on this. And so I want to put chiropractors on notice that you really have to be careful what you're doing in that. Anything you want to add to that, Scott, at all?
Yeah, well, and then you had mentioned there's a current investigation, too, about the opting out.
Well, opting out is, that one is still being investigated. So on that one, what's happening there is there's different chiropractic consultants, you might say, or different chiropractors say, I just do not want to participate in Medicare. They're afraid of audits. There's all this scare stuff going on. You're going to find out today, and this is how Dr. Munsterman and I work, and how Dr. Jacklich and I work, is basically you can check your fear at the door because I'm not going to scare you. Well, maybe that last thing sounded a little scary, but I'm going to just give you the facts. And our goal is to make sure that you feel comfortable being inside the Medicare system and enjoying working with it. What a lot of chiropractors thought is, I just don't want to. I'm scared. I'm afraid I'm going to get audited. So I'm going to somehow just decide I'm going to opt out of Medicare. And there's two ways that I've seen this happen. And you basically, chiropractors specifically cannot opt out of Medicare. If you want to treat a Medicare patient, you have to be in the system and you have to be billing the Medicare for the covered services. There's a lot of chiropractors say, I'm just going to go off the radar. I'm just going to do cash. I'm just not going to deal with it. And you just cannot do that. There was actually a case from one of the Medicare carriers called me up, and there was an issue where this was going through. And I go, how did you find this? Because they're not billing. And the person said basically it was the daughter of the patient who was trying to figure out why her mom was paying these chiropractors. Why wasn't Medicare covering it? And when they went through it, they found out that the chiropractor basically was just doing this cash system and not fulfilling it. So they're actually looking at that as intentional fraud, because you are knowingly depriving the Medicare beneficiary of a service that they should have had covered. So that's a big deal there. And there's another way that I've seen a lot of either groups or consultants falsely telling chiropractors that all you have to do is have them sign an ABN on the very first visit, check box 2, which means I don't want you to bill Medicare, and boom, you're a cash practice. You don't have to deal with it. You don't have to work with it. They also consider that basically intentional fraud, because you are intentionally depriving, again, the Medicare beneficiary of their services that they could have received. So those are two big things out there that I go in more depth. Today's more on the treatment plan, right. But I do want to notify people that, again, if they're doing anything that's touching either of those two things, they need to start looking at some help to make sure their policies are correct.
Yeah, exactly. Well, and I think it's just so important to let people know when we have this opportunity, Dr. Conway, and the same with, the audits that are going on. Yeah. Maybe just spend a minute on that if you would.
I'll just spend a minute on this one, because this one's pretty much over. But again, there's been an issue for all these years of chiropractors have a very, very high error ratio dealing with the submission of Medicare claims. We're the highest basically of all professions. And that was the key of what Dr. Jackson and I started working with about 5 years ago. And very promisingly, the work that we've done and the work we did with all the MACs and CMS and OIG, plus educating chiropractors across the United States, we've actually been able to reduce those dramatically. I mean, numbers that have never moved in 40 years are now moving in a very positive way, which is good. But until we get everybody doing the new system, the new way of doing it, which I'm going to show part of it today, there's going to be audits out there. So this was an audit that basically was about 2,000 chiropractic clinics across the United States. So anyone who's listening that did have this audit from SHS, it was scary at the time. They came back and they didn't extrapolate, which means they didn't go into very large numbers. And usually if they denied the claim, people are just kind of working their way through it. The problem I have with this, and why I bring it up is, and if you are in any of the audit process with this specific audit that was done, please know that the criteria that this company, SHS, used to deny claims was incorrect. They had multiple different criteria that they were using to deny that we have agreement with the MACs and CMS that are not correct criteria that they should have been using. So unfortunately, that's still going to perpetuate a little bit of our higher level for error ratio based on the number of people that probably failed this. But I just want people to know, if you're in this, it is good to fight it, because they use incorrect criteria. And if you need help on that, we can potentially do that at a different seminar to show you what those criteria were and how to fight it. But I want people to be aware of that it's still out there. The reason we have all these audits is mainly this error ratio. And if you apply what we learned today, it's really going to help us decrease that.
Yeah, exactly. And so let's talk about what we want to talk about today, huh?
Yeah, let's get to it. All right.
With the advent of EHRs and macros and all that, I mean, you make this classic statement, you can't 100% macro Medicare documentation. Talk to us about that.
No, I see it everywhere. Well, and I'll show you a couple macros that I have to deal with. And it's just one of those areas where chiropractors, understandably, you see a lot of patients in one day, and it's sometimes tough to keep up with the documentation. But in Medicare, you just cannot macro. It has to be very specific to that patient. I'll actually use an example. I have a denial from it's not Department of Justice, but it's pretty close to the high level of denial, an organization that denied the chiropractor, and I'm going to read what they denied it for, and you'll see it was mainly a macro. And so in this world, we're going to show you how you can still move fast. What Dr. Jacklich and I did in this agreement, that we basically have a universal agreement with all the Medicare carriers. And this agreement involved training all their staff and everyone agreeing to this is what chiropractic documentation should be. But our process was, we knew that the subsequent visit is where chiropractors spend most of their time with patients. So we tried to make the requirements on a subsequent visit less. We're not going to spend time on that today, but you'll find out that your requirements on subsequent visits are actually dramatically reduced, which helps you with your time. But the thing I'm going to go over today, on the initial visit, we did make that agreement that you have to put a little bit more time in, and you have to be a lot more specific about what you're documenting. And that's going to be helpful all the way through, but it was a way that we could actually help chiropractors to properly document and not have any conditions of time that would be affecting them. So yeah, the macros are just not there. You just can't macro Medicare. All right, so what are they looking for? This is an interesting diagram that you're looking at it. And when we first met with CMS and the MACs, about halfway through, I went up and drew this diagram. It's actually been something we've used ever since that day. We were out in Washington, D.C. when we had this meeting. And I explained to them that basically the blue box, for everyone looking at this is your initial visit. The green boxes are your subsequent visits. The yellow box is where you would have a progress evaluation. They're not required, but if you had one, that's where it would be. And then the red box is when you actually release the patient. So the very important things that we're looking for are, from here forward, everything you're working with, I want you to have an initial visit, but always looking at that red box. The completion, when you're going to basically release this patient, has to be determined as close as you can to the very beginning of care. And that is going to be one of the big factors. They're looking for something called an episode of care, meaning it has a start, a middle, and it has an end. Two currently, if you want to hit the next one. What we found in chiropractic is that chiropractors were doing these types of routines. There was no end. This one here, what I saw, and I've seen this for years, was basically, and again, these usually come from consultants or chiropractors just trying to do the best they can, but basically a chiropractor that will do an initial visit and then see a patient for, let's say, 12 visits, and then they look for another injury, sometimes they just change the diagnosis. They think that's all they have to do, and then they get another 12, change the diagnosis, get another 12, and it's just this pattern of going through, but there's never an end. So on this one, I'll see someone, they'll have a cervical diagnosis, and then amazingly, 11 to 12 visits later, they'll have a thoracic diagnosis, and then they'll move to a lumbar, and it just goes on. Well, they can see that. Medicare can see it. They know what's going on, and those are the people that they're actually targeting for audits because they can see that there is no end. There is no episode of care. It's just continually moving forward, but they're just trying to, it's not that they're gaming the system, but they're just moving forward with just those diagnoses. Now, this is one where basically, and I think every chiropractor has one in their office. It's basically that person that has come in. They started with you back in 1976, and they've just been coming in twice a week forever. And it's not unusual. I definitely want to get these out of your practice. So all you have to do is make sure that all your initial visit, have an end. But this is here where they start and it just goes. And if you can figure this out, if you go back and look at your HCFA forms and look at where your onset date would be, and if it's not within a short period of time, it's probably one of these that have to change. Now the next one, this is the one that's happening a lot now. And this one really, really has to change because everyone thinks they're doing it right, but they're not. Again, these are different consultants out there helping people, supposedly helping you. What this one is doing is you start out with the initial visit, and then you realize you're going to have goals, because I'm going to talk about goals coming up here. So you create these short-term goals, and then once you reach the goals, you set up another series of goals, and once you reach those goals, you set up another series of goals. So it's basically the reverse of the change of diagnosis. You're basically just going forever, but instead of doing new diagnosis, you're just changing the goals. They see this. And everyone has been told as long as you're going for functional goals, you're okay, but it's not true. You have to have an end to the treatment, and it's a key factor. So if you go to the next slide, this is it. It's called the episode of care. It has to have a beginning, a middle, and an end. And the red box is the key factor. You have to end it correctly. And that's what we're going to show, how you actually set this up in your office. I call this catch and release. So this is correct. This is what it should look like. You have initial visit. You have the subsequent visit, not saying it's 2, but it's, whatever number of subsequent visits, you release them, and then these darker blue can be maintenance. It's phenomenal to put them out on maintenance care. You don't have to. I had a big maintenance practice. So maintenance care is totally fine. When they have a new injury, new mechanism of trauma, you start a new blue box, do treatment, release them. New injury, new mechanism, treatment, or initial box, treatment, and then release them. This pattern works. This is what they're looking for. Keep doing that.
Yeah, and I think the biggest thing here to understand and to grasp, as chiropractic physicians, is that we need to develop a treatment plan, and it's based, like you said, Dr. Conway, in that episode of care. Sally comes in, she has an acute facet syndrome. We pretty much know what's wrong. I mean, we know what's wrong with the patient. We've diagnosed the patient. We know that there's healing time frame for specific tissues. We know the mechanism of trauma. We know the comorbidities, complicating factors, and we pretty much need to figure out how long that's going to be. And I know we're going to get into that here in just a minute. But that full episode of care, beginning and end, and then being able to manage throughout that process. And episode of care is what we really need to understand and encapsulate in our thinking.
You're 100% correct. And they can have chronic conditions when they come in. There's a way to work with chronic too. They don't all have to be just, I fell down today. But there always has to be an end when you set this up. So that's been one of the key factors and one of the things that the Max brought up continually. Say most chiropractors just go forever. There's no ending. And I've had where I've talked to different chiropractors, and they were basically using a criteria that if my patient had a subluxation and pain, that was my criteria that it was now AT. It was not maintenance because I actually had pain levels that I was working with. There were some functional things I had to change, and they had a subluxation, so it's an AT. And it's not, And so what I'm going to show you is using that criteria will let you have that person come in, twice a week or once a week forever or once a month forever. And that's not how Medicare is built. So we do have to change out of that. So the slide right now, if everyone just wants to take a picture on their computer or just write it down, this is everything I'm going to be showing you today is coming from here. This is the Bible of Medicare. It's the Medicare Benefits Policy Manual. It's Chapter 15, Section 240. So when you get into that Chapter 15, you just have to scroll down till you find the chiropractic section at 240 and print that off because everything on there is all the information that you need to know. All we've done and what Michael, Dr. Jacklich and I did was found out were the areas that seemed to be the ones that would, if we change those areas, would make the greatest impact for chiropractors. But everything has been there forever. Everything's the same. It's not like we invented new languages. We were able just to figure the solution out for this. So if you go to that and scroll down and you go into initial visits, which we're going to focus on today, you'll see that in there are these 6 components of an initial visit. And in there it starts out with history, which I'm not going to go over today, but it's important. Description of the present illness, very important. You have to have that in there in a very specific way. Evaluation of musculoskeletal nervous system through physical exam. You have to either have the x-ray or the part examination on this initial visit. Again, we're not going over that today, but these are all important to do. The diagnosis is very important because it has to correlate to the different vertebrae that you're working with. So the diagnosis is very important, and you also have to make sure that you're using the ICD-10 coding for that. And then comes the one, again, it's just, if you look, it's 1 of 6. But treatment plan, right above date of the initial treatment, but treatment plan, honestly, of all the work I've done all these years, changing the treatment plan is going to change everything in your office. So that's why we're going to focus on that today. All right, so let's go there. Again, that's the emphasis on it. So, and it's interesting enough, this treatment plan is not like it's very complex. There's only a few components to it. Basically, they want to know the duration and frequency, and they want to know specific measurable goals. And then the other part is you have to establish objective endpoint targets that can be measured to see if you actually reach your goal. That's the key factor. It's not just setting a goal, but they have to be related to the patient. They have to be related to condition. They have to be related to the mechanism of trauma that you're working with. And they have to be very specific. It's the specific part that's been tripping up chiropractors. And let's just go to the next one. So what I find across the United States when I'm working with chiropractors is they have, and these are the macros that pop up, but generally they have, these are the goals that I see. And again, reduced pain is always number one. It's never been not number one. Increased function seems to be another one that I see quite a bit. Increased range of motion. There must have been somebody that somewhere along the line that taught enough people that if you just put decrease a certain percentage on the SOS rate, you're set to go. That's not true, but I see that a lot. And then I see a lot of times too where they're decreasing pain from the words are more severe to moderate. So it's a little bit more specific, but we'll get into a better way of doing this. So these are things I see across the United States. And generally what happens, if you click next slide, you'll end up with a treatment plan that looks like this. And it basically says the goal of treatment will be to decrease inflammation and pain, increase range of motion, segmental motion, and flexibility, as well as increasing the quality of life of the patient. And I cannot tell you how many seminars I'm at where a lot of people just raise their hand and say, that's exactly what my macro looks like. And I'm like, unfortunately, you're toast. If that's what you're using, that's what you're working with, it's just not going to work with Medicare. And if you're going to be audited, they're going to work with that, and they're just not going to accept it. And this is a key factor. The other one I see a lot, too, is this improved patients' overall symptoms and complaints by some number. Unfortunately, what I see with that is every single patient's 20%, or every single patient's 10%, or it doesn't really match to the patient. And interesting enough, I want to give you an example. This is new, Scott. I just got this in. So there's groups out there called ZPICs. They're called Zone Program Integrity Contractors. They're a step below OIG investigating your office, which is really scary. But these guys are very serious. If they come in, they're looking for fraud and abuse, and they have the ability to really cause not a lot of fun in your life when they're investigating you. But this is a chiropractor that we're working with and helping. And interesting enough, here are the treatment goals. This is what the ZPIC reviewer said about this chiropractor's treatment goals. It says treatment goals were always written the same. For example, the initial short-term goal was always an immediate reduction in symptoms. Long-term goal was always to reduce the need for over-the-counter medication, increase segmental and regional range of motion, to decrease the palpable tenderness to 0 out of 4 or less, decrease measurable muscle spasms to 0.5 or less, and increase the patient's physical activities to pre-episodic ALDs that are commensurate with the patient's age and structural functional capacities. And basically said, this indicates that a plan of care was not individualized to the patient needs. So it almost matches what I have up there. And so they see it. I see it on everyone I defend. And it's very hard to win if your treatment plans are not specific. So that's why we're going to focus today. All right. So the macro goals, what can we do? Now we're identifying really what the issue is. So we just need to change some things. If you're going to have that pain goal up there, I need you to shift over and start thinking more quantitatively. I need you to start putting numbers in with your descriptions, what you're working with Medicare. So instead of saying just reduce pain, what you can do and shift over, most chiropractors use a VAS scale in their office or some sort of pain scale management with their patients. So instead of just saying reduce pain, if I put on there achieve a change from 8 to 5 on a pain scale rating on VAS, I am now just shifted. That little shift right there moves me from basically reducing pain, which is not helpful at all, to now something that I can definitely measure and work with and is a valid goal that Medicare will work with. When I get into mild, moderate, and severe, I see a lot of chiropractors. Obviously, it's better than just reduce pain, but what happens when you're just using mild or moderate, everyone's different. If I say the patient had mild pain, we all might be in some sort of zone, but if I say a patient was pain level was 3 on a scale of 1 to 10, everyone can zero in on that level of pain a lot easier. So again, I'm just shifting over from using these kind of like generalized terms, adjectives, to more quantifiable numbers. So if you want to use mild pain, you say the patient's pain was mild, rated at 3 out of 10. If you want to keep that in there. But the more you can start moving over numbers, it will help us. So the other thing too, and this is a big thing, I see a lot of chiropractors just grab some goal off the Oswestry or somewhere. Let's just pluck this one in there. What I really need you to do is have a goal that is individualized to that patient and meaningful to that patient. Thus, if they have a goal that, if they have an injury to their lower back, the more you can correlate the goals to what functional changes happened because of the injury and what functional changes are going to be necessary to get them back to where they were before they had the injury, that will be much better for you. And it's kind of like, I did a lot of work comp in my world, and I use this a lot in my seminars. I'll reach out or I'll ask the audience, say, like, how many people have had a work comp injury? And most raise their hand. It's pretty familiar around the United States. I go, did you treat that patient 3 times a week or 2 times a week forever? And they all look at me and would discuss, like, no, you can't. Who would ever do that, right? And I go, well, what did you do? And they said, well, we had to get back to pre-accident status, pre-injury status, and then we had to release them. I go, what were your goals? Well, we had to get the goals, so they start working through this whole functional thing. So not that Medicare is exactly like workers' comp, but it is a bridge that I can use in the short period of time today to help chiropractors understand that it's similar in that you're going to have a mechanism of trauma that we're not talking about today, but it's very important. So you have to have a mechanism of trauma for this condition, and then you want to have your goals that correlate to that mechanism and that relate to the injury the patient has and something you can measure. So let's go through some examples. Let's go to the next slide and look at those. So the question I get is, all right, what goal should I put in then? What do you want me to put down? And Mike and I, Dr. Jackson and I, work very hard in not requiring specific exact goals you had to have. Mainly because when you're dealing with the review system, if we said you had to have a range of motion, then a chiropractor didn't have it, then the MAC could use that against them, or the audit could use it against them. And so we made sure that there was no required goals. So nothing is, there's not one that's required. But what I'm going to give you is based on my experience of training all the reviewers on the other side that will be reviewing the information you sent in. What we taught them was these are the type of goals that we think would be beneficial if a chiropractor had them and work with them. So look for these. And the first one on the list was ADL type goals. It is just the way they look. It's what they're working with. And if you look with these Medicare patients, we're dealing with functional changes. So the ADL goals, which could be sleeping, walking, sitting, all the things you can find off of the outcome assessment tool type forms will help you with that goal. And what's nice about them, they are measured. So you can use numbers associated with these. It can only sleep for 3 hours a night where they used to be able to sleep for 5 hours a night. So you want to go from 3 to 5. It's very easy to use these type of goals in a functional setting that you can check. So those are really, really good to work with. I also find that, and again, this is just from working with all these reviewers, that if you work with pain level, so the VAS is something they can see very easily, that if it changes, it's a 7, then it goes down to a 5, goes back to a 9 because something happened, down to a 4. They can see things happening based on numbers on a scale, not just better, a little worse today, about the same. Those can be anything. But when you start using numbers, it really works well with the pain levels. Anything that's time-based, distance-based, all those type of things can work well. Range of motion is a very positive thing you can work with because it does reflect the functional changes that you're doing to this patient when you're treating them. And so if you have a patient that used to be able to have flexion of, let's say, 50 degrees, and now they can only do 10, well, then you can measure when they come in how well they're doing with that. And again, they're not requiring the goniometers and all the expensive stuff. It's really, they just want to know where are they starting at, where do you want them to get to, what is that goal? Right. So let's move on to the next one. Do you have a question, Steve? Or Scott?
Steve.
I know I moved.
By the way. The only thing I was just going to point out, one thing that we don't have on the list, but we do talk about at times, and that's just ask the patient. Ask the patient what their goal is, and as a part of the history taking, it's important for us to become and be good historians. Asking the patient what activities does the pain interfere with? It may not be sitting, standing, walking, sleeping. Right. The ADL, oswestry, neck pain, disability stuff. It could be them pulling on a chainsaw, or it could be them, trying to mow their lawn or whatever. And that's the kinds of goals that we're talking about here. And as Dr. Conway, you said so well, we have to be specific to the patient. It needs to be individualized to the patient. And we get that out of our history. And so when we figure out or find out, what the pain levels are, and we understand the mechanism of trauma and the injury and the diagnosis, it has to triangulate with the function and what's going on. And of course, you're going to talk more about that now. So I guess I just wanted to make that point, because you've made it in the past, that getting it as individualized as possible. And one of the ways to do that, is just ask the patient.
Well, and a key factor too, and I didn't bring that up before, is most of the time you're not getting these people back to perfect. Right? This is a generation. It's a little different now than when I graduated back in '83. A lot of my Medicare patients back then had lived through the Depression. Their bodies were a little bit harder. They didn't take care of themselves as well as now. You find a lot of what I call the whole food generation coming through. They're playing tennis. They have a little bit, they've had a different lifestyle. And so you may get this current generation down to no pain or certain areas. But a lot of these Medicare patients, the goal, like on this one here, the goal was 0 to 4 and 0 to 5. Well, that's not realistic if it's every patient, because some never were at 0 to 4 or 0 to 5, right? So if they were at normally a pain scale of normally at 3, that's your goal, to get them to 3, and then they're done. You've hit that goal. So it doesn't always have to be perfect. The perfect goals are, I would say, outliers that people look at and say, this generation is not going to be real. So let's deal with this too, because what happens when I do this is I say, let's talk about treatment plans. It's almost universal, where chiropractors start with frequency. They always start out, I say, what is your treatment plan? It's always 3 times a week or 2 times a week or whatever it is. It's a frequency per week or per month, but generally it's a frequency per week for a certain duration, and then they usually have some sort of generalized goal that goes with it, reduce pain. And so an example would be, 3 times a week for 4 weeks to reduce pain and increase function. And I see that a lot of chiropractors, that's their treatment plan. And that actually will not work. So what I need you to do now is flip this. Instead of having that goal last, I need everyone on the call today to start thinking of the goal first. So you set the goal, that makes them more important, right? So this is your priority. When you achieve these goals, you're at that spot where you're going to start releasing this or considering releasing this patient. So I need you to start with your goals, make them very, very specific to begin with. These are the goals I'm going to go through. It can be 3, it can be 5, it can be, I would at least have 2 to 3, because if you're just working up, they don't just want 1. If you just use pain scale as the one goal, it's just not going to work. You can have it as one of the goals, but really, really consider putting in the ADLs. I can't emphasize it enough. So have a couple ADLs, some sort of functional goal like range of motion, orthopedic tests, whatever you want to use. I have a lot of neurologists out there, and they have these neurological tests they use. Totally fine as long as you can measure it and it's reflective of the functional changes you're making to this patient. But start with the goal first. All right, then
something that pops to mind here to Dr. Conway. I think the author Stephen Covey said start with the end in mind.
Yeah,
and really kind of the same model, right?
That's exactly what we're doing here. And I cannot tell you how happy the Macs are that we're working this process. And it's the only reason that we're really getting that change in that error ratio. I mean, we've dropped from the 80s and 90% error ratios down into the 30s. They're ecstatic. I mean, I've been on stage with the carrier where they put up the screen and said, this is when, we had our training on our side to know what to look for and what to work with. And because the chiropractors in the state have been working hard and changing it, we're now down in the 30s. I mean, they're happy as can be too. So it really does make a difference finding that. Now, the duration, before it was kind of like a pattern, 3 times a week for 2 weeks, whatever you might be doing. I have to change that. So you have to look at this patient, and now what you're doing is you're saying, all right, I have George in front of me. He has all these physical examinations that you've done, so you know what his condition is. You know where he used to be, and you know where he is right now. And you know the goals, because you've set these very specific goals out, what you want to do for George. You now have to say, how long is it going to take me and George to get George to that goal? And everyone's different. And so I want you, instead of saying, 4 weeks or 2 weeks and things like that, I want you to look and say what you think it's going to be. And it may be 2 months. It may be 3 months. It may be 6 months. It may be a week. Whatever it is that you feel the time necessary to get those goals achieved with the specific person in front of you is going to be it. And now you have a zone. And this is where you're starting to set up that red box from the beginning. It doesn't mean exactly I'm picking July 4th at 3:30 in the afternoon. He's going to be fixed. That's not what I'm asking about. But I am saying that you can probably estimate, based on all the information that you've gained from this patient, that you're going to be somewhere around July 4th. It could be July 1st, it could be July 15th, whatever it may be. But you're going to find a zone that you are going to be closely estimating that this person is going to be released. And that's a key factor we have to work with.
Right. And it all falls in line with evidence-informed process in our clinical decision-making. I mean, the evidence tells us, what acute low back pain, chronic pain, we've got some protocols, we have some guidelines to follow. We have our experience, clinical experience as clinicians, and the patient's preference, and then identifying what tissues have been injured, what type of mechanism of trauma, what type of complicating factors, are there any treatment barriers, to slow the progress up, and then we use our best guess, right, or maybe the crystal ball, whichever works better, but we have to arrive at
one
that we feel a recovery time. So
I agree. I had one doctor say, I don't have a crystal ball. I said, well, go down to Walmart and buy one. Put one in your office, because basically what it is. You have to have, you're the doctor, you have to have some sort of estimate when you're talking to this patient of how long it's going to take. Now, it can change, and I do get it, and we'll talk about some complicating factors in a minute, but you at least have to get some sort of estimate that's realistic for that patient and realistic for the people that are going to be reviewing your case. So that's a key factor on this one. So it's a big deal. Now you come with frequency last. So now what you're doing is you now have the goals, you know how long you feel it's going to take you, and then you figure out how many times you need to see George for this. And what's nice is in the past, and we've worked really, really hard on this, and some of the MACs are still moving through it because I know we're talking to people across the United States here. So there are a couple that used to have screens up. So and you're saying, I know, right at 22 or right at 12, they cut me off and it didn't matter what was going on, I got cut off. Well, we have worked with them to remove those screens. Now, it takes time for someone to do it, but the goal is of all the MACs is not to have those screens on if the chiropractors are honestly trying to have an endpoint, they don't need those screens like they did before. You can understand if you start out and you see all these chiropractors just treating a same patient 3 times a week for 30 years, you have to have some sort of screen in there. So by the change that we've been doing, and we've earned this by decreasing our error ratio, by doing this correctly, by doing these treatment plans, they're removing these screens. So the treatment number is not as significant as it used to be. Right now, that duration of whatever that is, and the goals are the more significant parts. So the treatment plan, the treatment section of it, you just figure out, is it going to be 12 visits, 20 visits? Whatever the visits you think it's going to be, that's what you put in. So it's going to be 20 visits, 4 months, and these are the specific goals. And that is the base of a treatment plan.
Yeah, I think for some doctors, Dr. Conway, it's almost hard for them to believe that.
I know,
it's almost hard to believe, because they're used to a number.
Well, in the past, too, just so people understand, there had been this animosity. There had been this attacking back and forth, and that's the one thing Dr. Jackson and I did differently. We went in and we did not meet with the mid-level people. We only met with the senior VP and up is the only people we met with because we knew they were not vested in the process. They wanted to just have a good outcome. And so we started looking at what was causing these outcomes to require them to do these screenings, that were requiring all this different stuff. What were we not doing correctly? And quite frankly, what were they not doing correctly on their criteria? We had one carrier that was requiring an oswestry on every single visit as one of their criteria, which there's not a single chiropractor I know of that does that, and they shouldn't do it. So we had to change their internal criteria, which was affecting chiropractors on the outside, and then we also had to work with the chiropractors, make sure they were doing what we're showing here today with this treatment plan. So the key thing now is I need you to shift over and start with the goals, get the duration, and then you figure that number out. And that number is going to help you in the subsequent visits, which I don't know if we'll talk about today, but it's a factor you have to work with. Now, there are some things, because no matter where I go, everyone's like, okay, that's all well and good for, some, but I have these other patients that's just tough. They either don't want to follow a treatment plan, or they want to come in just now and then, or, they have different transportation issues, there's exacerbations, there's all these different things you have to work with. And so now you can work with it. See, before, if you had kind of a wishy-washy, just the usual 3 times a week for 2 weeks, 2 times a week for 2 weeks, and we hit a goal, then we hit a new goal, stuff like that, it was hard if there were changes because you could modify and just keep going forever. If you have a very set, specific time frame that you want to be done, and there is something that pops up that can change it, usually I see transportation or illness is one of them. Let's say you have this thing set up, and they said, well, that's great. Please understand, my daughter has to bring me in, and I can only get in twice a week. So if you were initially thinking, well, it's going to take me at 3 times a week, it's going to take me 4 months, but really, you potentially still can do it in 4 months, so we can try the 2 times a week, see how it works. Or you can say, no, it's just not, I just know it's not going to work, so I'm going to extend this out to 6 months. You just note it and say, look, this is my original, what I thought I could do. Because of their issue, they can only get in this date and these times, this frequency. It's going to take me a little bit longer to go, and that's why I'm going to have my treatment plan duration out to here. And they understand that. You just put that in your documentation so they know what's going on. Exacerbation seems to be the biggest issue I'm working with, because a lot of chiropractors are using exacerbation just to do a new onset date, that new blue box, where you had the new diagnosis based on exacerbation. You can't just do that. And this is a big, important factor. If there's an exacerbation, if you're working along this treatment plan and there's an exacerbation, and believe me, they do happen with this population, you then have to stop and look and say, does this exacerbation that's affecting me today and this patient today, does it totally change the treatment plan? My treatment plan is no longer valid. This changes, it's a game changer. It's not going to continue to work what we're thinking. Like, say you're working with someone, they fall down a flight of stairs. That's a big game changer. So you have to start over with a whole new initial visit, which means you have to go through all the examination, all the history, all the stuff that you're working with, and come up with a brand new treatment plan that's reflective of that new mechanism trauma type injury that's pretty severe. But if the exacerbation is just not enough that it's not a game changer. I don't have to change it, but it is going to modify my current treatment plan. Well, then you just modify the treatment plan. You put a note in, say, look, the patient picked up their grandchild. We weren't expecting it. It exacerbated lower back. It's not where we have to start a whole new treatment plan, but it is going to extend out our treatment by a month, or I'm going to have to increase my frequency where I thought I was decreasing it. So instead of 20 visits, I'll now be up to 30. As long as you explain it, you show the correlation to the treatment plan, and your treatment plan still has an end predicted or estimated, they're going to be totally fine with it. That's a key concept to work with. Anything else, Scott?
You've taught us. Yeah, I was just going to say you've taught us, really well the episode of care, and like we mentioned earlier on, we have to have that in our mind, and did that episode of care change, for that, Sally started out with a Facet syndrome. She got run over by a car. Did that change? Are we in a new episode, or is this a flare up, or a monkey wrench in the current episode, and we need to extend the duration, we need to increase the frequency, and all that. And so, but we all, out of the context, as you said, that episode of care for that patient, for that condition, individualized goals, individualized treatment.
And you can't just change the diagnosis and call it a new onset date and move forward. You have to, anytime, you have to think of this too, anytime you change that onset date means you have a brand new condition, you have a brand new issue, and you have to do an entirely full initial visit. You can't just change and go. And that should change a lot of the workings within the chiropractor office, because you can have a treatment plan of 3 visits. It could be just there came in, there's not a lot there, and you're all set to go, 3 visits. But if they do come back in, you have to, and it's an active treatment, and you want to move from maintenance to active treatment, you have to go through the full evaluation, including an E&M code that you have to charge for, getting back to that initial stage. A lot of people will change diagnosis, and I look at the onset date, and they're being audited, and I'm like, well, where's the exam? Well, we just, we didn't want to charge him an exam for that day. Did you do any exam? They're like, well, no, it was an exacerbation, so we changed the onset date and started a new set of treatments. It just doesn't work. Medicare sees it, and it's going to be very frustrating for you and for them during the audit process. So let's give you an example. This is just, you can read it, what's up there, but this is like a patient that comes in. So let's show you, because these don't have to be extensive. When we were working with the MACs, there were a couple, and they threw out all the, the records doctors have been sending in. They're like, okay, you look at this record. What do you see? And it was interesting to see that the ones that put in like the macros that filled up like 20 pages, everyone could see that those were not real, that they didn't do all that work on that visit, that they didn't match the patient. It was just a series of macro buttons that these people were pushing, thinking they were looking good. And we actually had some that were just some arrows, but you could actually understand what was going on from the keys that they were using, and they were actually perfect. So more doesn't necessarily mean you're going to be safer. So on this one here, let's look at an example for you. So if you click the next one for me. There we go. So if you look at these goals down there, again, we have the sleep 5 hours without waking up. So that's the goal that they were at. Wherever you'll have in your history where they are now, but the goal is to get them so they can sleep 5 hours without waking up. You want to decrease the VAS from 8 to 4. I want to increase the cervical rotation on the right from 25 to 50 degrees. I think it's going to take me 4 weeks, basically a month to do this, and then it's basically going to take me 12 visits. So this is not difficult. It has all the components in there. This is on the minimalist that I would work with. I'm trying to show you very minimal, you know what I mean? So I think it doesn't have to be a lot. I would hope you would put more in here, but I'm just trying to show you that you can go down to this level and it's still valid. But if you go to the next slide, you'll see the comparison. This is what I've seen forever, right? Patient will be seen 3 times a week for 4 weeks to decrease pain, increase range of motion, and cervical function. So you can see you have the components there. You have the duration, frequency, and you have a goal, but the goals are not specific. There's no way to know if you made it, and there's no way to know if you're at the end of that 4 weeks. And when you're comparing both these things, say you get to the end of the 4 weeks, on the bottom, I know, can he sleep 5 hours? If he can't, I haven't made it there yet. Is he only at a 6? I haven't made it. If he's only at 35 degrees, I haven't made it. But if he's close to all these, I can say, look, I was predicting 50. Looks like we're only going to get 45. That's it. It's just staying there. And then I'm done. But at the top one up there, I never really know when I'm done. And if you're a reviewer looking at it, you never really know, did they make it or not? And that's a key factor to think of when you're doing these from both sides. So what we got next?
Yeah.
Unless you want to add
No, the only thing I would add to that, when you say you're done with active treatment.
Yeah, and that's the key thing.
That's a great opportunity. Yeah. Great opportunity
to
to talk to
maintenance.
the patient about maintenance therapy.
Yep,
Exactly.
exactly. And that's where you use the ABN too. So the ABN's got a whole nother world. It's amazing. I think it's kind of a simple form, but when I go and do seminars, it sometimes takes hours depending who's taught them things. But the ABN is only required when you're moving a patient from active treatment to maintenance. And that's when you have them fill out that ABN. You can have them fill it out in the beginning for the non-covered services, but it's not required. All right, so let's do a summary of this so we get what's going on here. You want to get an idea of really what they were before they got injured. You want to know what their mechanism of trauma. We didn't go over that today, but I would consider treatment plans number one, mechanism trauma the second most important thing that you need to deal with when you're dealing with Medicare. And again, that'll be a future seminar we can work with. But you want to figure out the prior status and a reasonable expectation status to get them, these goals to get them back to where they were before they got hurt. You want to look at that mechanism of trauma. How did they get hurt? Is it pretty severe? Is it going to take longer? All the different factors with that. Starting with ADLs is just a good way to go. Make them very specific and measurable. Add in your physical goals. Make sure your duration of time is reasonable and matches all the other information you brought in. And the frequency, again, those of you that had those screens in the past, you still may see a couple of those out there because we're working on this change. Nothing in Medicare moves quickly, but we have basically moved mountains in this whole process already. But know that the frequency is, they're going to look at it, because if your frequency is 200, obviously you're way out in left field. But if the frequency matches all the other information you have and it matches the goals and all the other conditions, you're going to just be fine with that. So those are the goals for that. What are we having next?
Well, Dr. Conway, we've got some questions now that just came in, and I know we're getting close to our end of our time here. But let me go ahead and state here. When a Medicare patient comes into the office and asks if we take Medicare, and this is an office manager asking this question, the answer is yes, we do. And pardon me?
Go ahead. I'm sorry.
Yep. And the answer is yes, we do, and that we request they pay in full today, and then they turn it into Medicare for reimbursement, or I can offer them ChiroHealthUSA. We are a cash practice and non-participating. Am I doing this the right way?
All right, let's start that one over again. Sometimes these are long questions. Hit me on that one again.
Yep, I'll hit you again with it. So when a Medicare, and this is a non-par provider in a cash practice, asking this, and it's an office manager asking, when a Medicare patient comes into the office and asks if we take Medicare, the answer is yes, we do, and that we request that they pay in full today, and then they turn it into Medicare for reimbursement, or I can offer them ChiroHealthUSA. Am I doing this the right way?
Well, you have to be, obviously using ChiroHealthUSA is a very positive thing to do. So that's good, because they actually have all the procedures and protocols that you can use when working with it. But they also tell you that if you're dealing with a active treatment, right, the patient has active treatment for covered services, which would be the adjustment, then you do need to bill for those services. Now, if you're non-par, then they would pay you up front, and then you would have to bill Medicare, and the patient would then get paid back from Medicare. Does that answer the question?
I believe so.
Okay.
Another question is, why wouldn't we go off number of visits? If I say 3 months and they do not come in to get treated, then 3 months meant nothing, versus I believe after 6 treatments, they'll be 50% better.
All right.
So this doctor is asking, what if they just set the treatment plan based on a number of visits versus having frequency and duration?
Yeah, if you go back to the requirements, it's requiring frequency, duration, and specific measurable goals. Those are requirements for Medicare. And what I find a lot with chiropractors that do, let's treat you for 6 visits, see how you do, and then we'll treat you for another 6 visits, see how you do. It's just another mechanism of that. Remember I showed you the goals at the end, right, where you treat you, then you achieve those goals, hit new goals and stuff like that. You just keep changing the bar of where you're going to work with this person, keep going on. And that's not how Medicare wants it to work. They want to have an episode of care up front so they know exactly what you're working with this patient, what your desired and specific endpoint is.
Okay. And then we have some questions, different ones revolving around Medicare Advantage plans. Can you just maybe give us some general observations about Medicare Advantage plans? Because some don't cover, some cover more.
I know. So it's so hard with, cause I've stuck with Medicare because that's universal across the United States, and that's what we work with. If they're having trouble with Medicare Advantage plans, because each one is each state has different rules. There's different things in each state dealing with Medicare Advantage plans. And so I usually have them work with their state associations who really understand the local, the different carriers that are doing it and how they're responding, what they're working with. But we have found that if there is a problem, because we've had some of the Medicare Advantage plans actually put out false criteria or false requirements that Dr. Jackson and I would work with CMS, and they would directly contact the Advantage plan to make sure they weren't doing that. So, and again, we work through the state association to help them with that. So it's hard to do Medicare Advantage just on a national level. Each state I try to do the best I can, but on a national level it's hard.
So we have another question. Can a Medicare patient sign a Medicare opt-out form aside from the ABN that allows a chiropractor to not bill Medicare? I think we kind of talked about this, but it'd be worth.
Yeah, there is no patient opt-out form. Technically chiropractors cannot opt out of Medicare, so they have to understand that it's specifically written there, which is sad, but it's just what it is. And so there's many chiropractors trying to do this wraparound so they don't have to bill Medicare, and there's just no way to do it. So if you're going to touch Medicare patients, you have to be in the system. And once you're in the system, you have to be willing to bill for the covered services. Now, and you look on the ABN, there's some rare patient that, they have the benefit and they just do not want to use it, right? And so there is a box where they can say, I seriously do not bill Medicare, do not tell them I even exist, all those different things, but those are really, really rare. And if Medicare sees you're actually using that, it's almost like the ABN signing on that second box where, don't bill Medicare. If they see you doing that and find you doing that, then they consider that very serious. Mm-hmm. So it's really,
we'll probably have one.
The one I'm trying to get, and hopefully across to all the people here, is there's more. Unfortunately, we only have an hour today, right? So I did the best I could with the one thing I think is a key factor. You change these treatment plans, believe me, it's going to make a difference for you. But Medicare can be very, very easy. We've really changed the entire landscape within the Medicare carriers by going in and training all of their people what to look for. So the fear should be taken out and should be like, this is something I want to do. Because once you set these treatment plans up and get them and release them, they're on maintenance or they're just released, there is no fear. Everything's working. It works really easy for you. And there's 16,000 new Medicare beneficiaries every day going on, and they all want to have chiropractic care. They really see it as a benefit. So I'm trying to keep people in rather than trying to find a wrap out to get out.
Well, and here's the thing, and this is probably, a good conversation to end on. And by the way, those that ask questions will be following up with answers for you after the presentation. But the fact of the matter is that there's rules, when it comes to Medicare. But really, as we see this play out, and the doctors that are doing treatment plans, with setting patient goals, specific goals, having their duration of care, known in terms of with the patient, and then the frequency of visits. I mean, patients, number one, like that. I mean, overall, they like to know that there's a plan. But number two, the doctors have been providing better care. They've told us that. Yep. This has been a product of us actually doing what we should be doing. At the end of the day, we should be developing a treatment plan. And we should be having some accountability in what we do. We do some great work, and it's very effective. And now here's a way that we can provide that to patients in a very organized manner.
I agree. And I see it on the audit defense too. If I have a good treatment plan, there's no way I'm going to lose. I mean, it is the key thing that's dealing with. But I see so many of these cases where these chiropractors have given phenomenal care. I mean, just done a great job. The patient needed the care, but their treatment plans were just the reduced pain. And they're using that, saying there's no specific measurable goals and denying it and winning at a lot of different levels. And so if the chiropractors just change to this level, it's going to decrease the one main thing that they're denying them on if they get audited. It's going to give them a lot of peace of mind doing this.
Yeah, very good. Very good. Well, just to end this, we're at the end of our time. It's been great working with you, Dr. Conway. Just for those of you to know that Dr. Conway and myself have put together a Medicare playbook. It outlines all of the key requirements that are necessary for good documentation and treatment planning and all of that. And so you can go ahead and visit the BPA website on that. But we just want to thank ChiroHealthUSA for all that they've done and helping us get this important information out to masses. Thank you, Christy, again, for all you've done.
Thank y'all so much. What a great webinar. I know people are messaging me right now that you have questions, and y'all were like lightning fast with some these too. But just know that I have already compiled them into an email to Dr. Conway and Dr. Munsterman so we can get those answered. And everyone that is on the webinar today, we will send you all of the questions and all of the answers so that you don't feel like you missed out because we didn't get to your to those questions and answers today. Thank y'all so much. Y'all are amazing, and that was such a very incredibly informative webinar, and you packed a lot into it in 55 minutes.
I know. We talk fast. One way to do it.
Well, I want to thank everyone for attending the webinar series today. I hope you enjoyed it. Please fill out the feedback at the end of today's presentation. That's how we know what topics you want to hear about, what speakers you would like to come back. And based on the engagement today, I have no doubt we will see Dr. Munsterman and Dr. Conway again in the near future. Just a reminder, next week, Dr. Fabrizio Mancini will be here to talk to us about how to have a fab life. Then we are going to follow that up where we're going to be focusing on associates for the rest of August. How to accelerate your practice with associates is going to be August the 14th. We're going to take a week off and then come back with how to, once you've integrated that associate into your practice, how do you use that as part of your retirement plan and exit strategy from the practice? A lot of great things coming up. Webinar series is posted all the way through the end of September, so go check it out. Register early. Thank you again for joining us today. We look forward to seeing you next week, same time, same place. Bye, everyone.